It's my pleasure now to introduce Dr. Jennifer Brown, Associate Professor in the Department of Psychological Sciences here at Purdue, and together with Professor Murray from South Africa, she received the WGHI Mildred Elizabeth Edmondson Research Grant in 2023. And their project is on utilizing community-based participatory research to culturally adapt the sexual health intervention for South African adolescents.
Well, good afternoon. I'm Jenny Brown from the Department of Psychological Sciences. It's a true honor to be with you all today. And on behalf of my South African colleagues, I want to extend my thanks to WGHI for the funding to support this work. I'm going to be talking to you a bit today about using community-based participatory research to adapt an intervention to improve sexual health among South African adolescents. I want to acknowledge that I have no conflicts of interest to disclose. I'm going to be speaking briefly about some previous work that was funded by the Bill and Melinda Gates Foundation, along with the Anna and Harold W. Huffman Foundation, and then going to be spending most of my time speaking a bit about the pilot work that was funded by WGHI. So by way of background, we know that unfortunately South African adolescents continue to experience a number of health disparities and experience higher rates of both unintended pregnancies and sexually transmitted infections like HIV. Within South Africa, we see that Black South African adolescents in particular experience marked health disparities relative to their white counterparts. And unfortunately, most of the interventions that have been developed within Western contexts and have not been appropriately culturally adapted to the unique cultural context of South Africa. I'll be telling you a bit about some of the work that we've been doing using a methodology called cultural consensus modeling, which is a mixed quantitative and qualitative approach that can help us identify potential targets for cultural adaptation of interventions. So in this study, our primary aim was to adapt an existing nationally delivered sexual health intervention that's delivered in schools called Love for Life. This has been developed by our community partner, Love Life. And what we wanted to do is use CBPR to incorporate some of our previous findings into the intervention's adaptation. I've had the great privilege of working with the University of the Free State. If you're not familiar with Bloemfontein, South Africa, it's there on the map. It's a quick hour-and-a-half flight from Johannesburg. And you see there the metropolitan area of Bloemfontein, where the University of the Free State is. And we've been working primarily in the Mangaung Metropolitan Municipality. Due to the long history of apartheid in South Africa, the metropolitan municipality seen here is a historically Black township. And unfortunately, you see pervasive poverty that persists in this region of the country. So we've been using cultural consensus modeling, which is a mixed quantitative and qualitative approach where culture is defined as those shared beliefs, behaviors, or norms that are held by a particular group. It allows us to take a naive perspective and identify from the ground up what are those potential factors that might be shared beliefs or behaviors or norms within a group. It also lets us look at statistically whether there are unique subpopulations or subgroups that hold different sets of beliefs, behaviors, or norms. And so our first study that we conducted in South Africa using cultural consensus modeling was conducted with South African adolescent girls. This was a 4-phased mixed quantitative and qualitative study. And what we found at the end of this study, where we were really interested in what were the most acceptable contraceptive methods and HIV prevention methods, was that there was very little awareness of more modern, efficacious contraceptive methods. And similarly, there was very little awareness of more modern, efficacious HIV prevention interventions. Instead, most of the young women were most familiar and found different methods like abstinence or condom use to be the most prevalent and acceptable methods. So we conducted a second study to see whether or not the findings from our original study would hold when we looked at a larger sample of young men and young women. And this was a school-based study with over 2,000 adolescents, again about the same age. These were Black Sesotho-speaking young men and young women. We were working with the school districts there, and we recruited 5 schools that were delivering the sexual health curriculum developed by our partner Love Life, and 10 schools where that curriculum was not being implemented. And across this study, which interestingly, a topic for another day, was conducted during COVID-19, what we found was that results held. There were similar patterns of acceptable contraceptive methods and HIV prevention methods, both among young women and young men, and identified clear gaps in understanding about those contraceptive methods and HIV prevention methods that are available. So our goal with this study was then to take the information we had gained from our previous cultural consensus modeling studies and utilize a community-based participatory research approach with both community partners and adolescents to help us think about how we could adapt the existing sexual health curriculum. We've been very fortunate to partner with three main community partners. The first is Love Life. Love Life is a national South African community-based organization with the goals focused on youth empowerment, youth development, and health, in particular sexual health and reproductive health. They have this really fascinating program called the Groundbreakers program. And what they do is recruit youth leaders to serve as peer interventionists, senior peer leaders, and they're who we worked with on our youth advisory board that I'll be telling you a bit about. Love Life has developed the confusingly similar Love for Life curriculum, which is a sexual health curriculum that's delivered in many of the South African schools nationwide. We also partnered with the Ministry of Education. We had worked with them previously in our school-based study, and they're the ones who implement this curriculum. So we were really keen to get their input on what would be acceptable adaptations to the existing curriculum. We also worked with the Ministry of Health, which is the public health infrastructure, both nationally and locally within South Africa. Our CBPR approach was really centered on this idea of having youth co-researchers. So enrolling and enlisting and recruiting young people who would be co-researchers with us to help think through how could we best adapt the intervention. We were very fortunate to partner with a fierce force. Her name is Nosana Sondezyazi, who's pictured up there at the top, who is our facilitator and has a lot of experience in delivering sexual health intervention and HIV prevention interventions with youth. We established a youth advisory group that served as co-researcher. These were youth leaders from the Groundbreakers program who agreed to participate. So we had 7 adolescents who formed our youth advisory group. And so what we did is held a series of virtual workshops. We had 6 virtual workshops. And what would happen is our facilitator, Nosana, would go through the existing curriculum and iteratively with our youth advisory board would gather their input about ways to adapt the content, the format, consider other images, other material that may be most useful for young people receiving this intervention. So they would engage with these workshops. They were very animated and they had a lot of opinions, which was great. And so we were soliciting their content and expertise since ultimately they'll be consuming this intervention. We recorded those intervention sessions to make sure we weren't missing anything and then transcribed them as well. So how did we go about adapting the intervention? Well, this was an iterative process utilizing our community stakeholders and those relationships along with our youth advisory board. We first wanted to identify content that was lacking in the existing curriculum. For example, one of the most highly efficacious methods to prevent HIV is something called pre-exposure prophylaxis, or PrEP. That's the use of antiretroviral medications prior to being exposed to HIV to prevent HIV. This was not on the radar of the young people we were working with. And so we wanted to work with them to think about how could we incorporate that content in a meaningful way. We also worked with our community partners and youth advisory board to think about what are those additional instructions that may be helpful for some of the content and the activities being done. The young people also would tell us that we needed more graphics, we needed more images. And so this is an example at the bottom that the great team of undergraduates and grads that I work with developed to illustrate some of the contraceptive methods that we were talking about in some of the activities. We then iteratively revised the intervention back and forth across the set of partners and developed a final intervention manual. We then wanted to make sure we were staying aligned with what our community stakeholders wanted from this intervention, and so we had ongoing meetings with leadership from Love Life, considering some of the content changes, since ultimately they're the owners of this intervention and the ones that disseminate. And then we also conducted focus groups with community stakeholders of parents, those from the Ministry of Health and Ministry of Education, to solicit their input about the revised intervention. So what do we take away from this study? First of all, it was an opportunity to see whether or not we could incorporate some of those findings from cultural consensus modeling to adapt interventions to be more appropriate for the cultural context in which they're being delivered. We were able to use adolescent-driven CBPR to work collaboratively with youth to help us design the intervention to be more appropriate and responsive to their needs. We were also able, through this iterative process with an intervention workshop facilitator, to think about the ways that the content may fall flat if teachers are going to be administering this. You can imagine that this is the content that health education teachers are delivering in the public schools. So we want to be as explicit about what we're asking them to do as possible with the intervention. We were also able to solicit ongoing input from our community partners to think about how to optimize this intervention to be both acceptable and feasible for its delivery. I'm really passionate about making sure this research gets back to our community partners on an ongoing basis. And so we've been having ongoing discussions with Love Life nationally about how we can perhaps implement this new module nationwide, and then also trying to be responsive to the needs of our partners. And so they've requested a number of policy briefs, brief white page overviews about the research, and so very grateful for our community partners to do this work. This truly takes a village. This work wouldn't be possible without phenomenal partners in South Africa. And so I just want to, in particular, note my co-PI, Dr. Lochner Murray at the University of the Free State, and the great team at the University of the Free State, along with my US-based collaborators, along with the fantastic graduate students, undergraduates, and research staff I have the opportunity to work with. The picture you see up there are some of the groundbreakers live in action on a trip to South Africa, and they're just really a force for good there. So I thank you for your attention, and I'm happy to answer any questions that you might have.